Good morning, everyone, and welcome. I'm Sarah Kott, Senior Vice President of Programming at The Hill. Thank you all for joining us today in person and online. And thank you to everyone joining us online for Moms Matter, Closing the Maternal Mental Health Gap. I would like to thank our sponsors, Sage Therapeutic, for their support of this very important discussion. As many of you in the room are keenly aware, right now, the United States has the highest maternal mortality rate among high-income countries. Mental health and substance abuse issues are the leading cause of pregnancy-related deaths. This week, the U.S. Department of Health and Human Services announced a national strategy with recommendations developed by the Task Force on Maternal Mental Health. Today, we will hear from advocates, maternal mental health professionals, administration officials, and members of the U.S. Senate. Before we get underway, a few housekeeping notes. If you would please turn your cell phones to silent for the duration of the program, but please join the conversation on social media. You can follow us on Facebook, X, and Instagram at The Hill Events using the hashtag #TheHillMentalHealth. And with that, I am delighted to introduce our sponsor perspective. Please welcome Vanessa Proctor, Senior Vice President of External Affairs at Sage Therapeutics.
Good morning, and thank you so much for joining us here today. My name is Vanessa Proctor, as Sarah mentioned, and I am with Sage Therapeutics. Last year, the FDA approved Sage's first and only oral treatment for PPD. And as tremendous of an accomplishment as this is, because it medicalized PPD, and for the first time recognized this disorder not simply as a state of mind or a moral failing from mothers, but for a real urgent medical condition that needed to be treated with urgency. But our approval in this important field is just one step in many steps that many of you have taken to ensure moms and families have what they need moving forward. And today, I am extraordinarily honored to introduce you to one advocate whose name is Stephen D'Achille, who in 2013 lost his wife, Alexis, to PPD. In 2013, Alexis did not have access to the important information required to make important health decisions for herself and her family, nor did she have a healthcare provider who recognized the signs and symptoms and the urgency to treat. So please join me in listening to Stephen's story. And I want to thank you in advance for joining Sage, The Hill, and all advocates today to make sure no other mother or child or family is left behind. Thank you.
Alexis was, bar none, the most electric person that walked into any room. She was extraordinarily beautiful, extremely smart, but at the same time, so humble. And I don't even think she realized the superpowers that she possessed and her ability to make everyone around her better and happier. Postpartum depression was, I don't even know that it's a term I'd ever really even heard or given any thought to. I vaguely remember when she first became pregnant, somebody saying, hey, you better watch out for those baby blues. And I think that's probably the term that I was more familiar with. You know, Alexis wasn't the girl that this happens to. We weren't the couple that this happens to. And we just had this fairy tale pregnancy. She never got sick. It was like seamless. It was perfect. And it was extra hard after Adriana came because everything else up till that point was so easy. And so then what's called a code blue delivery occurs. And basically the code blue delivery, that means either mom or the baby's life's in danger. And I remember, like most moms, it's like they're overlooked. But at the time, all eyes were on our daughter because she's the one whose life was at risk. And I remember trying to talk to the doctors, and I looked at her from across the room, and she was laying in bed, and she's like looking my way. something changed. And her eyes were like glassed over, and it was almost like there was nothing behind them. And I don't think she ever like recovered from it. It was like she was a shell of a person from that day forward. She never slept. All she did was cry. She really believed that our daughter had brain damage and it was her fault. And so she tortured herself. And she said, I think we should give Adrian up for adoption. We'll find a great home for her. We'll find the most loving parents, and everything will go back to normal. That was when I was like, man, we have a really big problem here. Bigger than I could have ever imagined. It just started like this 2.5 week spiral that it was hard to imagine someone could get that sick that quick. And to see someone that was always so together fall so apart, and every day just worse than the previous, and it just anti-anxiety medication, sleeping pills, nothing worked. And this is, weeks, maybe a month after our daughter was born. She lost 50 pounds in 5.5 weeks from the day she delivered. When you hear about a suicide person, everyone always says, that wasn't Alexis, or that wasn't Carol, or that was, like, no one knew that person was capable of doing that thing. She looked at me and she said, nobody cares about people like me. Nobody's gonna help me. And she said, I'm gonna kill myself just like I just said it, really clear and really succinct. And it's so disgusting. And so shameful. For me to be here today, the ball was dropped so many times, it is sickening. Her last doctor's appointment was an appointment where she was advised by the LCSW. She had been Googling things, and she thought that she would be a candidate for estrogen patches that would, help her rebound and get her life back. And the doctor just said, you're not a candidate for that. And, at the end of the appointment, she just said, listen, you're not cut out for this. Just go on birth control. I don't think it's smart for you to have any more children. And I believe that in that very moment, she had resigned, and she knew that it was going to be over soon. We're making strides and we're moving in the right direction. There's facilities across the United States today that there were none 10 years ago. There's new medicines, there's new technologies. People are starting to get it. And so, that's really my hope with all of this, is that, this is a big step to push the needle further. It feels good to be a part of the change.
Thank you again to Sage Therapeutics for their support of today's program. We'd now like to welcome Kathleen Koch, contributing editor at The Hill, joined by Senator Maggie Hassan of New Hampshire and Senator Katie Boyd Britt of Alabama.
Good morning, Senators. I'll give you all a moment to wipe away the tears. Whew. Very hard to watch. And before we get started, I do think it's important that we define what we're talking about, because women in pregnancy and as new mothers can face really a multitude of mental health issues. For instance, before pregnancy, there are women who may have pre-existing conditions, have bipolar disorder, could have schizophrenia, substance use disorder. They become pregnant and then their conditions worsen. And then there are women who experience issues during pregnancy, like anxiety. We had a member of my family who had a miscarriage. She became pregnant 3 months later and then had terrible anxiety in that first trimester. She was just so terrified she would lose the baby again. And then there's what most people think about, I think, after the delivery, right? Postpartum depression. But then there's also PTSD. Women can have trauma during birth. So, I'm just so glad to have the two of you here. You've been such champions when it comes to helping women, new mothers, pregnant women. I'd like to ask you both, what are you most concerned about right now when it comes to maternal mental health in the United States?
Look, first of all, Kathleen, thank you for having me, and it's great to be here with my colleague, Katie Britt, and good morning, everybody. Look, we know that the leading cause of maternal death, or two of the leading causes, are mental health, postpartum depression, and addiction. And so we also know that there are more and more birthing units closing. It's harder and harder for women to get expert labor and delivery care or expert care when they have an obstetric emergency. And we know it's harder and harder for women in this day and age, especially pregnant women who already have a child or two, to actually make the time to get to all those pre-birth appointments. So there's a lot of work to do to coordinate care, to remove the stigma of being pregnant and having mental illness, or having just given birth and having postpartum depression, or being pregnant and having addiction, and having healthcare providers who know how to treat you for the addiction while you're pregnant. So there's just a lot of work to do. The United States has unacceptable rates of maternal mortality and morbidity, and we have to change that.
Senator Britt, what worries you most?
Yeah, well, Kathleen, thank you for hosting us. It is an honor to be sitting alongside Maggie here, and I think it is so important that we continue to talk about this in a bipartisan way, because this is not a Democrat or Republican issue, this is an American issue. And I think what worries me most is that we're not talking about it, which is why I am so proud to be engaged in this dialogue. We have to let women know what actually may happen during pregnancy, after pregnancy. We have to talk about it in a way, as Senator Hassan said, that destigmatizes these things. And it's not just about the women, it's about the women's support system as well. It is about letting the people around her that love her, her husband, her parents, siblings, children, kind of sort of know the different things that a woman could be going through. And so I think that general awareness, participating in the conversation, raising the bar about that across the country is critically important. And then some of the things that she just said, I was proud to partner with Senator LaFonza Butler on NIH Improve Act, and that is, working to help figure out what is happening with maternal mortality in this nation. It's moving in the wrong direction.
So is that all about research? Is that
That
correct?
is about research. Mm-hmm. It absolutely is. And it's about getting to, the numbers in 2024 should be going down,
right.
And instead they're moving up. And so what are we missing? Unfortunately, Alabama has the highest maternal mortality of any state in the nation, and it disproportionately affects the African American community. So what are we missing? And how do we get those resources to individuals? We also have many maternal care deserts. And just as Maggie was talking about, how do we make sure that these women have an opportunity, whether it's through telehealth or whether it's through other opportunities in more rural communities, that they get the care they need in the prenatal, the postpartum phase, and in the early childhood development phase.
Now, are you two taking that on? Is that part of the Rural Obstetrics Act that you're working on together?
Yeah.
Those maternity
that is
deserts?
so just to give you a sense, so New Hampshire over the last decade has lost 11 birthing units, and the average travel time in New Hampshire to a labor and delivery unit or center is now about 40 minutes. You add bad weather to that and mountains, and now it's even longer. So what we're trying to tackle is a couple of things. One is how to make sure that every emergency room in America has the equipment and the trained personnel to handle an obstetric emergency. Even if you don't have a labor and delivery unit, even if you don't have obstetricians on staff, what do docs and nurses need to know if they are confronted with an obstetric emergency. So there are a couple of ways to do that. Training, so the bill would fund training, grants for the equipment that you need, and then the other idea here is a telehealth service that's nationally available, so a doctor, a staff in an ER can hook up to 24/7 obstetric experts to handle an emergency wherever that's taking place. So those are some of the things that this would do. It's, you know, the other challenge here is that in New Hampshire we have some birthing units in more rural areas where the number of births is actually kind of low, but you got to keep it fully staffed. And so the costs here are different in rural communities, and we got to make sure that we are supporting those providers.
So you're saying if a pregnant woman anywhere in the U.S. has, suddenly needs to rush to the hospital, many hospitals wouldn't know what to do with her if they didn't have a labor and delivery?
I would never want to say they wouldn't know what to do with her, but if your area of expertise is not obstetrics or gynecology, and you don't have a lot of experience delivering babies and you're presented with a complex obstetric emergency, we know that there are experts who really can save women's lives in these moments, but you have to know the latest techniques and you have to have the right equipment.
You do, and you mentioned earlier anxiety during pregnancy. So imagine being one of these women who she is saying is 40 minutes away, or in Alabama, maybe over an hour away from that. And, all the different things you're dealing with. I remember being pregnant and thinking, you kind of have a wave of emotions that I experienced, excited, but also really nervous. And, you want to make sure you're doing the right things for the baby, and that you're putting the baby in the best place possible for to survive and thrive. And so those types of things weigh heavily on a woman as well. And so I think making sure that we are equipping these communities and these women with resources to ease that and to be prepared in case of emergency is critically important.
Sarah mentioned in the introduction the task force on maternal mental health came out just this week with their recommendations. Right. I know Senator Hassan, this is pretty special for you because it was your triumph, right? The triumph from New Moms Act that mandated the creation of the task force and this new national strategy. How does it feel to see it happen, come to fruition?
So I am really grateful to my co-sponsor, Tom Tillis. This was another bipartisan effort in the last Congress. And the report is really important because it gives concrete steps that we can take to really address some of the gaps in maternal health care around the country, including mental health and high-risk pregnancies. So Dartmouth Hospital up in the Upper Valley of New Hampshire is a rural academic medical center. And it is really focused on the fact that a lot of women in that part of our state can't get physically to appointments, for instance, at the end of pregnancy, when you're supposed to go once a week, or if you have a complex pregnancy, you're supposed to go more often than that. But if Medicaid dollars or private insurance dollars can be used to buy devices so women can do telehealth appointments or provide transportation or get some other kind of mobile and telehealth care, we can make really great strides, both for so-called physical conditions. And I will stop here and say, I am looking forward to the day when we stop talking about mental health as something separate from physical health. It is all connected, right? But we really, this bill generated the report we're seeing. This is about having a coordinated and focused approach in the United States of America about what we can do to really make sure that pregnant women and moms get the best possible care in the richest country on earth.
One of the major policy successes in this space was the passage of the American Rescue Plan Act in 2021 that allowed states to extend the Medicaid postpartum coverage. I assume most of you know it used to be, it was 60 days. 60 days was all they gave. And then as a result of this act, it was extended out to a year. And then there was a measure that passed in 2023 that made that where it wasn't going to expire, it was supposed to sunset in 2027, but now this will continue. And of all the states in the country, I think we have 46,
Yeah.
right? 46 that are signed on. So that's a major accomplishment and very exciting. But Senator Britt, I wanted to ask you, because in the recommendations of the task force, there's a pretty big ask. They would like to see paid family leave, universal child care. What do you think? I mean, you stated the situation that Alabama's facing. It's a crisis. So can you support measures that broad, that sweeping? And could they pass the Senate?
Obviously, the devil's always in the details. But when you think about childcare, that's something in particular that I'm working on right now. Trying to find a pathway forward where we create opportunity, but not an entitlement. I mean, I go back to my own life and my own just issues that I've dealt with or challenges that I've faced or that my sisters had or whatnot. I mean, I remember being in law school. So I went back to law school with a newborn and an 11-month-old. On the scale of bad ideas I've had in my life, and I have had a few, that one is number one. And then the moment, as I was trying to do that, I remember having, a 6-month-old that the daycare called and said, he's sick, you have to come get him. And I thought, well, I can't miss torts. So you know what happened? My son laid on the ground right there on a blanket in my torts class. And thank goodness my professor let me do that. But then when I saw childcare moving into the professional life, it was so expensive. I mean, it was $1,785 a month for my 2 children in Birmingham, Alabama, and this was 13 years ago. And I think, how can we make this affordable? If there are women who want to re-engage, or men who want to re-engage in the workforce, I want them to have that opportunity. I don't want the lack of childcare to be an impediment. It also goes back to what we're talking about in states like Alabama. They recently, the legislature just passed an effort to try to make a dent in this. One thing we've done really well is first-class pre-K. It's actually been #1 in the nation, and free first-class pre-K, and we continue to expand that. So we have a lot of work to do. I want to be a part of the conversation. I understand how it impacts families, impacts women, and I think we have to do it in a way that's responsible, that can allow us to continue to do it, particularly in the financial situation we're in the country.
And I will just note, there is a bill that would limit, for instance, would cap a family's expenses for child care to 7% of their income, right? Which is a way that you have a sliding scale. The wealthiest folks don't have the entitlement because they don't need it, but it's a way of investing in child care. There are other bipartisan discussions and teams going on about this.
So these are in the works.
They are in the works,
yet.
right?
And I'm working on some stuff right now too.
The 7% bill is introduced, led by Senator Murray, and my team will tell me who else is on it if I ask them. But I will say, listening to Katie, I am just struck by both how unusual it is to have 2 children under a year old in law school, but how similar, but how many stories that resonate like this. I was thinking about the Medicaid coverage piece. When I had our second child, I had had a miscarriage between the 2, which had been a devastating 12-week unexpected event. I had a son with severe disabilities, which had been a very traumatic experience. And I wasn't allowed to lift more than my baby girl with a son who couldn't walk for 6 weeks, right? And so women are in these positions all the time. I'm blessed with a wonderful, caring family and everybody pitched in, but these experiences happen day in and day out all over our country. And there is no reason that we can't have a coordinated, thoughtful way to help moms and their children at this most critical stage.
Yeah, and that's one thing, so I'm working on a bipartisan proposal to engage in the child care space, because I feel very passionately about it on a number of levels. And Also, I have just introduced, alongside Marco Rubio and Kevin Kramer, the Moms Act. And the thought behind that is how can we support these moms in the prenatal, postnatal, and early childhood development stage? How do you know what resources? I sincerely remember, I was living away from my family. I was in New England. Yeah. I was in New England, so up your neck of the woods.
I have family in Alabama, so we talk.
This is good. But I remember being away from everybody and finding out I was pregnant and kind of sort of not knowing what to do next. And then also remember looking at my baby girl in the hospital and thinking, wait a second, you're going to send me home with her? What am I supposed to do? And so just those resources, parenting classes, or there's a grant proposal in it. How do we make sure that these women can have cribs or diapers, or what mental health support? So it's a three-pronged, three-titled piece of legislation. But really, the goal is how do we make sure that women know what resources are out there and they're able to take advantage of them to support them through this journey? Because I think that's essential, and I don't think it's something we're doing right now, and we're not doing it well.
Senator Hassan, you're working on the Healthy Moms and Babies Act.
Right.
You've introduced that with Senator Grassley. What would that do?
So that's, again, a look at how do we provide coordinated care for pregnant women and moms. And it's with Senator Grassley, we are looking at investing in a way that Medicaid could reimburse for the care coordination, especially for pregnant women who have complex medical needs, but really for any pregnant mom, really to have a maternal health home. And it also would invest in more telehealth for pregnant women and moms, and again, focus on the mental health needs. Again, it is really, won't surprise anybody in this room because it is pregnant women and moms around the country who have been advocating for this kind of coordination. But we really have a healthcare system that doesn't really address mental health, especially for pregnant women and new moms.
And if you look at the data that's out, Maggie is exactly right. It's 23% of maternal mortality is due to mental health. There's a mental health connection in that. And, we look at the numbers, I think 1 in 8 women suffer from postpartum, but only 50% of those are diagnosed. Right. It goes back to the stigma. It goes back to not talking about it. And so I think we have to do better, particularly in this mental health space, and let people know that mental health is physical health, and all of it is tied into one.
And that there are resources out there, and while we don't have enough people in the mental health workforce, telehealth can be a major bridge here. And that's one of the things, just making sure that pregnant women and new moms have devices, mobile devices that they can use to connect to telehealth. Sounds like a very straightforward thing, but it's really, really, there's a gap there, and it would make a big difference.
Is it just me, or is Congress, though, paying more attention now than ever before to women's health issues and acting on them? You did get pretty speedy passage of the Triumph Act. Are you encouraged, or are you frustrated that we've had to reach this crisis point, right? A crisis point before we saw this kind of action?
I think this has been an ongoing challenge and problem in our country for a long time. But I will say that having, about 25 women in the United States Senate
that's what I'm talking about.
And
helps.
Bipartisan women's dinners where we all look at each other and say, have you looked at this data? This is outrageous. And then we begin talking about our own lived experiences and that of our sisters and our daughters and our mothers. And, this is the importance of having a diverse Congress. It's the importance of moms speaking up and pregnant women speaking up, and of advocacy around the country. This doesn't happen just because a bunch of women senators sit around at dinner. It happens because people talk about their lived experience. They're brave enough to share mental health challenges. They push back at the stigma, and they insist that we focus on the things that we all know a lot about just from our lives.
Yeah, I am I'd say both. One of the things, my most frustrating thing after being here for 16 months, or the thing I was most surprised about, is just that this place is not working the way that it could and should for the American people. I think there are so many of these incredible ideas, many of which you've heard up here, and a lot of them don't get to see the floor, and we don't get to have that debate in front of the American people, and then the American people lose as a result. So one of the things I am committed to, I'm on the Appropriations Committee, and dug in and was like, when's the last time we did our job? When's the last time we finished this on time? It was 30 years ago. I mean, 95 is the last time we did all 12 bills individually by themselves. 97 is the last time we did it.
But we finally did all 12 bills this year, but we were late. But
we were 174 days into the fiscal year. But I want us to see it work. So I have a level of frustration there, but I have great hope because I work with really good people, a lot of really good people on both sides of the aisle that I know want to see things better. They want to do better. They want to be better. They want to make a difference for the country. And I think where we share a common goal as Democrats and Republicans, even if we have a different idea of how we achieve that goal, I think it is incumbent upon us to sit at the table and figure out a path forward. And I think that's what you're seeing right here. And this is too critical of an issue for any of us to walk away from the table. So we're going to keep going. I promise you, right this one, and make a difference.
Absolutely. And we are hearing the same thing from constituents, regardless of what states we represent. And that's, my message to people is speak up, share your experience, and keep insisting because there's lots of bipartisan interest in this area, lots of bipartisan bills we didn't talk about that would make a big difference here as well. And I'm really grateful for your coverage of it.
I am, and I would like just add one more thing. Thank you for covering things like this. Because so often the only things you see in the media are things that are clickbait, that are salacious in nature, that maybe don't tell a whole story. And so the American people don't actually get to see the two of us talking about the same issue, wanting to work together, wanting to make a difference. I think if they saw more of that, not only I think would it be good for the soul of America, but I think it would inspire this type of work on the state level as well. And so I feel good about it, and I really appreciate you taking the time to cover it.
Same here.
Thank you for the rare show of bipartisanship. I think we'll all agree we need a lot more of it. So Senator Maggie Hassan of New Hampshire, Senator Katie Boyd-Britt of Alabama, thank you. Thank you for the great discussion.
Thank you so much.
Please welcome Cheyenne M. Daniels, race and politics reporter at The Hill, joined for a panel on barriers to postpartum care with Adrienne Griffin, executive director of the Maternal Mental Health Leadership Alliance, Chandrika Balgobin, medical director at Innova Women's Behavioral Health Services, and Stacey Braveboy, SVP of Public Policy and Government Affairs at March of Dimes. Welcome.
Well, thank you all so much for joining us today. This is such an important conversation. I think the topic of mental health is one that's becoming a little bit more talked about generally, but we know statistics show the outsized effect that it has on pregnant Black mothers. And so I want to take a moment. As we're seeing some of the stigma around mental health decline, where is it or why is it still impacting pregnant Black women when it comes to being able to ask for that help and say, I'm struggling. I don't know how to relate to my child. I don't know how to pull through this pregnancy. I don't know how to talk to my partner. How do we start to have those conversations?
Right, so thank you so much. First of all, thank you everybody for being here, and thank you to Sage for sponsoring this event. And to my lovely panelists, we got the memo on the purple, and we framed Chandrika so nicely. So back to that question. So, let's just look at the numbers, right? 1 in 5 women will experience anxiety or depression during pregnancy or the year following pregnancy. And we know Black women are at even higher risk, as are other historically marginalized populations. So women of low income, Native American women, there's lots of women who are at higher risk. Why is it so hard for Black women in particular to talk about this? Well, we know that mental health across the board has been so shameful, but particularly in the African American community, right? And, there's the strong Black woman mentality. Black women of color, have been disproportionately impacted by child protective services. So if acknowledging that you have mental health conditions, there's real fear that your child may be taken away from you. So I think there's a whole host of issues that make it harder for Black women to ask for help.
Yeah, and tell me a little bit more about that, what you see in your own research and in doing this work.
Sure. So I'm a reproductive psychiatrist. I work with OBGYN and maternal fetal medicine, also known as high-risk pregnancy. So some of the things that we see include sort of having the conversation, introducing this as a potential consideration in pregnancy and the postpartum period, understanding that this is a possibility, and being able to ask for help, normalizing conversations about the potential for anxiety and depression and the prevalence that we may see. Also, the prevalence is higher in high-risk pregnancies, and as we know, there are factors with regards to proactively seeking help and seeking health care and barriers that may affect the ability to do that. And they manifest in pregnancy in a way that can affect the prognosis of pregnancy and potential prognostic factors in the postpartum period, affecting outcomes both for the maternal side and baby as well. And that comes up as well in the NICU setting as well. So it's also about education and understanding expectations, and then also being able to consider resources. So the ability to screen appropriately and refer. One question that I often get from colleagues is, if screening starts, how do we refer? And how can we ensure that there's adequate referral sources? And that comes up in different media. The Maternal Mental Health Report Card, one of the domains includes access to clinicians and programs. So that is one consideration as well. So it's multi-layered, it's complex, and we need to do better.
Yes, and Stacey, is there anything you would like to add?
Most definitely. So what my colleagues have shared is everything that I wanted to share with you, but I want to add just a few more additional personal comments as it relates to this. So one, I think it is wonderful that we're all here and that we're highlighting the importance of maternal mental health. And so I do agree with what the senators have stated earlier. When we're not able to go into a room and separate health and mental health, when we can look at it in a holistic approach and way. As an African American woman, I will tell you, who's also a mother, as we talk about the stigmas that face the African American woman in the community, they truly do exist. They exist from the stereotypes of if their resources are available. We're challenged with, if we come forward and we say that we're suffering after giving birth to a child, that we're dealing with postpartum depression, or if in some cases this postpartum depression could lead to substance abuse. It could be you're willing to say, I'm not able to take care of my child. How do I get help? Where do I go? Many times it's because you're not educated on where to turn to, or you don't feel comfortable talking to your provider. And then, of course, providers are not trained, as you've heard, or in states and providers. There's not support to be able to educate or offer those services or identify those services in the hospitals, in NICUs. And we've heard this from the story, the presentation we saw earlier. It is being able to identify those things earlier. My personal story, I want to open up and I want to share. I don't want to have it viewed as a stigma not to tell it, but I will tell you that I also suffered with postpartum depression. It was me trying to figure out who do I call, where do I go to get help, and you would think, me being right here in Alexandria, Virginia, wonderful, wonderful team of providers, but nobody readily identified it for me. It was me being proactive. I guess that's why I'm an advocate that's in the space. I know that's why I'm an advocate in this space. It was me being proactive to go and seek out groups to be able to talk to. And then I know we'll get to this hopefully we'll get to it a little later, but I've heard it mentioned in the first panel with the senators. There is a lack of providers, therapists, psychiatrists, networks for women of color, but not only women of color, but for women in general, to be able to go and seek help. And then once you get on a list, is what I had to do. I had to get on a list in order to be able to go to a group to talk about having postpartum depression. And then so it was me advocating for myself that we were able to identify who I needed to be able to go and talk to. Because I would take my daughter to the daycare and then I would pick her back up because I was starting to do half days because I had to return to work. And I would just look at her and I was thinking, what in the world are we supposed to do now? And so what I would do is I would get into bed, I'd go to sleep, and the only reason that I would go to sleep, because I was depressed, I would go to sleep, but the only reason I would wake up, because I knew the child needed to be fed, I knew that she needed her diaper to be changed. So there was still that part of, I need to take care of this child, but I suffered in silence. And so there are a lot of women who suffer in silence when it comes to postpartum depression, but depression and have mental health issues coming from giving birth to a child.
Yeah. Can I just pick up on something?
Absolutely.
Right. So I'm so sorry that you suffered. And it gives you insight into all of this.
Yes.
Right. And I do this work because of my personal experience as well. 22 years ago, I had a son. I had significant postpartum depression. He graduated from college last week. He moved back home last night. So we did get through it. But it changed my life.
You do get through it.
And we have to move from the place where we're expecting the mom to find help.
Right.
When we collectively, but the medical community needs to be talking about this issue from the moment a woman is pregnant, right? We can't wait till the postpartum period. Most of the cases start during pregnancy, whether it's anxiety or depression. We need to say from the moment a woman is pregnant, congratulations, it's great when you come to the OB, we're going to test you for all these things every time we see you. We weigh you, we measure your belly, we listen to baby's heart rate, and I'm going to ask you how you're doing. Normalize it. Anxiety and depression are the most common complications of pregnancy and childbirth. But you know what? There's resources, and let's get you connected with them before you fall off the cliff into the pit of anxiety and depression, and then you're trying to climb your way out. I remember somebody gave me a card for behavioral health. I'm like, what is that? That's like, get a hold of your behavior, woman. Get yourself together. When what I really needed was somebody to say, hey, let's talk about this. And then trying to navigate the complex behavioral health system when I never navigated it before.
Right.
I apologize. I didn't know the difference between a psychiatrist and a psychologist. I had no idea what I was doing. And like you said, I would get on lists for things. I would call therapists. They wouldn't call back. Like, we need to give moms the knowledge and the resource to prevent them from falling off the cliff.
Absolutely. And thank you both for sharing your stories. I want to delve into this a little bit more because one of the things I think that we consistently hear, especially from Black women, is about the birth experience itself and how traumatic it was and what they endured just in that moment of actually giving birth, those hours leading up to it, those hours in the room. And Chandrika, I'm curious for you, how does that traumatic experience, whether that's not being listened to, being forced into a C-section versus a vaginal birth, things of that nature, how does that impact maternal mental health and lead to the recovery postpartum?
Absolutely. Thanks for this question. It's not talked about enough. Approximately 1 in 3 births are considered traumatic. And one of the considerations is that it's not recognized. It's considered, part of the experience perhaps in a way that it shouldn't be. One of the dynamics that we often see in our line of work is the feeling of loss of control, that dynamic. The ability, or the lack of ability rather, to not be able to feel like one is able to bring up the concerns that they might have in the moment, or sort of regret, or worse, blame themselves, or feel like it's a personal failure. My body didn't cooperate. So those are some of the things that we sometimes hear. So recognition that this may have happened. One of the protective factors in the data is having trust in the healthcare team, being able to perhaps have supports, being able to have the conversations with partners, for example, to be able to recognize sometimes in certain situations where it may feel like one's life is at risk or baby's life is at risk, that can be traumatic as well. And being able to have the ability to talk to someone or engage. And in some hospital settings, including ours, we do have psychologists inpatient to be able to offer support as well, but also working with the obstetric team during the postpartum visit. We've had experiences over the past few years where pediatricians may also provide screening, and they do see parents, and that's a natural way to also consider. So also considering pediatrics, they're seeing babies and families, so considering screening in those settings as well. Now, when it comes to how it affects maternal mental health specifically, it affects trust. And when it affects trust, it's hard to be able to engage and ask questions. Sometimes it leads to avoidance of needed health appointments. So for example, the ability to walk into the hospital where something happened, something scary, something really scary happened, right? Can be very triggering. And so being able to identify that and address such a barrier, for example, or considering a different office setting, so offering flexibility. Another consideration too is considering those triggers and how that might impact bonding and attachment, for example, because when one thinks of their birth experience, they may consider their baby, and how does that impact the ability to bond, and addressing that barrier, for example, because there are longer term outcomes if not addressed proactively.
Absolutely. And Stacy, there was a recent evidence review by JAMA Psychiatry that found maternal mental illness is the leading cause of pregnancy-related deaths for Black mothers, being twice as likely to experience maternal mental health condition, but half as likely to pursue treatment. What are some of the barriers that are keeping Black mothers from being able to either seek out that treatment or even access that treatment?
Excuse me. The response to that is twofold. It is one, getting over the stigma and the fear of being able to come forward and talk to your providers, being able to seek out therapists. I think that another focus that I want to make sure we bring into the conversation is maternal deserts that exist across the country. And it is not just in rural areas, but it's even in certain urban areas and settings as well. So being able to address those issues, and many times in some of the rural areas, you do have Black women and women of color, but women in general, who may have to go far, drive far, take several vehicles, or come up with alternative ways of being able to get to not only during the birthing process, but before, being able to get someone that they can talk to about the feelings that they're having and the emotions. So I think being able to have a conversation about maternal deserts is important, and you bring it into the fold of the conversation as we start to also look at how do we talk about maternal mental health and the impacts itself. I think that how you address it also, it's about educating. It's also about where you meet the families. March of Dimes has partnered with Mama, looking at an app that is actually used in the NICUs. It's presented to the moms, it's presented to the dad, it's presented to the family, where you're asking the questions, and it's safe for you to say, how are you feeling at this moment? Is there something that we can do? And so that's tracked, and then immediately the physicians and your attending therapists that are there are able to identify someone who can come and have that conversation with you in the NICU. And so we heard very early on at the beginning of this program and this convening, we actually heard by watching that screening of the father telling the story of how his wife felt at that moment being there in NICU. So I think it's about education. It's about doing it early. It's about taking away the stigma that comes from expressing your concerns, and then also continuing to educate the communities, educating people of color, Black women, birthing people, about why it's okay for you to seek help and making it really available. I know I pointed out and talked about the maternity care deserts, but also looking at telehealth. How do we start to have those mothers who are not able necessarily to get to providers, to get to therapists, know exactly where to go to these groups that I kind of mentioned earlier with me being right here in Alexandria, Virginia, but being able to find those, but being able now to rely on telehealth, telemedicine, and being able to connect in that way. And I think now I mentioned one app, but there's several other apps now that we're looking at partnering with to be able to connect moms early on.
Absolutely. Stacey, you started speaking about essentially a support group and having that support around you and those who maybe might be able to start to say, hey, is something going on, and be able to start to have those conversations. And I want to stay on that for just a moment. And Adrienne, if you would like to chime in here on what does a support system look like, a healthy support system look like for somebody who, again, through the entire pregnancy, not just that postpartum, but from that moment where you find out you're pregnant, you're going to be a parent.
Yeah.
What should that support system look like?
Oh my gosh, I'm so glad you asked this, because this is one of the things I'm really passionate about, is like support groups, peer support. So, not everybody who experiences a maternal mental health condition necessarily needs to see a therapist or a psychiatrist. There's lots of things that we can do to support mom along the way. And it starts very, very basic with self-care. Right? Sleep, the most important, most effective, least expensive intervention, right? If a new mom in particular, can get 4 to 5 hours of connected sleep, right? Not waking up in between, that's the minimum that you need to survive at a normal rate. You can go for interrupted sleep for a short period of time, but if you're up every 2 or 3 hours for nights on end, for weeks on end, I have heard psychiatrists like Chandrika say, I can give mom all the medication in the world, but if she's not sleeping, she's not going to get better. So sleep. Social support is so key. My mother, I remember talking to her about this. She's like, when she was having us, her mom lived down the street, her sister lived around the corner, all the moms were at home. There was this built-in village. We don't necessarily have that anymore. We don't live near our families of origin. Many moms go back to work. There's some crazy statistic of 25% of new mothers go back to work within 2 weeks of having a baby.
Yes.
How is that possible? It's insane. We can't do this to women. So social support, whether it's, just commiserating, saying, I went through this too, let's talk about it. It can be providing meals, watching the baby, holding the baby so mom can take a shower or take a nap. Support groups are so important, whether it's an informal support group, moms in your neighborhood or through your church or through a community-based setting. There's so much that we can do before we even have to connect with therapists and psychiatrists, right?
Yes.
Yeah. Not to take away from your business or anything,
But being able to get adequate sleep, being able to have conversations and have multi-layers of support, so important. And practicing through the pandemic, prior to the pandemic, many services were in person. Out of necessity, many services pivoted to telehealth. Support groups have also switched to virtual, allowing accessibility. And also, as Stacey mentioned, removing barriers to care. So not having to consider childcare, not having to consider traffic and timing and such, and being able to sort of engage in a way in one's comfort zone. One thing that we've noticed is that in terms of the appointment show rates, for example, it improved with telehealth. So that also helped with engagement.
And I do want to add something to the conversation, is the importance of doulas and also midwives. Midwifery has also plays an important role. And so, of course, by increasing that, making sure that states, as we know, continue to expand in terms of funding and reimbursements for those are helpful. But I also think, you piggybacking a little bit off of your earlier question, how do you help women of color? How do Black women address this when it comes to this stigma? I think we now see a rise, an intentional rise in doula care and also midwifery with that assistance being able to come in not only to the mother or the birthing person, but also to the family as a whole, being able to go through that process that can also help with their delivery. And when there is I won't say a disconnect, but there's a fear that exists, is being able to help people get through that process during the pregnancy, not only during the pregnancy, but after the baby's here for that journey as well.
Absolutely. And, we're in Washington, so I would be remiss not to mention our politicians. So we're going to pivot just a little bit to talk a little bit more about what we can see from our political leaders to help address this. And so, Adrienne, we saw the Task Force on Maternal Mental Health report to Congress this week. As a member of that task force, I want to take a moment to ask you very quickly, what was maybe the top thing that stood out for you in that report, or something that really just resonated, struck you? And then on the flip side of that, how do we start to bring this issue to our politicians' attention?
Okay, wow, I could talk like half an hour just on this. I'll try to be brief. So what really struck me with the work of the task force and what came out in the report is how important it is to engage not only about mental health during this time period, but other issues like gender-based violence and social determinants of health. Like, these things all come together. We had this opportunity in the perinatal period to really change the life course of not only the mother, but the child. We think about this during a routine pregnancy and first year of baby's life. Mom will interact with a healthcare provider about 25 times. Wow. 25 times, with the opportunity to say, hey, new mom, how are you doing? What's it like living at home? Do you have enough diapers for your baby? Whatever, right? And to connect mom with resources that literally can change her life and the baby's life. And so that, I think, is what really, to me, resonated with the task force and with their various recommendations. So then, how do we engage politicians more? I can't believe that we actually had a national task force on maternal mental health. Like, that is amazing. The White House supported it. Congress mandated it. Our politicians are starting to pay attention. So, for example, one key thing that has happened over the last several years is that Medicaid, postpartum Medicaid, typically, so if a woman goes on Medicaid during pregnancy, and Medicaid covers about 40% of births in our country. So it covers a woman during pregnancy, and then it was 6 weeks postpartum. What we've seen now is that most of the states have extended that postpartum coverage for a full year, in part because of the data that we've been seeing about maternal mental health and the impact. So we hear about these suicides, right? 23% of maternal deaths are by suicide and overdose. And a lot of those are happening in the late postpartum time frame, 6 to 9 months. And so if a woman lost her coverage at 6 weeks, she's not seeing a healthcare provider. So by extending that coverage for a full year, we are going to be saving lives. So I think, the time is now. We are talking about this. We have our elected officials actively engaged. Yes. So I got about 5 more good years of work left in me before, I want to start thinking about retirement. So I got 5 years to push this through. So yeah.
Absolutely. Chandrika, how would you like to see our political leaders addressing this?
Similar to what Adrienne said, extending coverage through 1 year. We've seen individuals who have lost coverage prior to the extension who lost coverage at 2 months postpartum. 2 months postpartum. This is 2 weeks after a 6-week postpartum visit, and not allowing the ability to engage in care in a sustainable way, providing resources as possible, but it really limits the ability to access care. So that would be one major priority to consider.
I think for March of Dimes and for myself, we align with a lot of the things that Adrienne has mentioned with her alliance, and so our policy priorities are very similar. I think it's important that I would call on not only DC and right across the Hill, and here on the Hill, I would also say state. Hold your state elected officials responsible, especially your governors, your state legislatures, where a lot of bills and acts can be passed to be able to support people at the local level. I think for me, I would probably would be remiss if I didn't say on the federal level, we're advocating for, in the appropriations process that's happening now, it is to encourage Congress to pass support for HRSA funding. You heard the senator mention research and research dollars that are needed. I think we need to also encourage some of the things that March of Dimes are advocating for in the appropriations process is also an additional $10 million to help fund the maternal health hotline, maternal mental health crisis hotline. I think things like that are important. We'll continue to advocate for expansion of dollars put forth towards, as we've all mentioned, the need and the necessity for telehealth and telemonitoring of those patients, moms, and birthing people who don't have access quickly to doctors and providers, because the maternal deserts is definitely something that we've also got to be able to look at. So yeah, I could give you a whole laundry list of things I think we all got to be doing, but not only is it incumbent on the federal, congressional electeds, but it's also an important topic that we all here in this room and people who are joining us via streaming live, that you've got to talk to your elected officials at all levels, regardless of what your political views are. This is something that is impacting all of us across the country. Yeah. And the one thing is, well, I don't have kids right now, but I tend to make sure I drive this home. You're not here without having a mom. So everyone in this room and everybody who's watching, everybody who reads, they all have a mom, and it's about being able to take what you hear here, what you're reading, and go back and talk about why it's important, because it impacts each and every one of us, directly and indirectly.
Can I just, you mentioned the hotline.
Yes.
So the National Maternal Mental Health Hotline. So we talk about not having enough resources. This is a free resource available to anybody, anywhere across the country. The number is 1-833-TLC-MAMA. It has now been in operation for 2 years, has helped over 35,000 women and families. It is a free resource. I also want to point out, this is an issue that is completely nonpartisan, right? We have, over the last 10 years or so, passed 3 pieces of legislation addressing maternal mental health, all bipartisan, bicameral. Each one of these pieces of legislation passed the first time they were introduced. It takes an average of 7 years for a piece of legislation to become law. First time. In the last Congress, there were over 10,000 pieces of legislation, 300 or so passed, and 2 of them were on maternal mental health. One established the task force on maternal mental health. The other provided funding for the National Maternal Mental Health Hotline and grants to states. And so, again, this is an issue, like Stacey said, everybody has a mom. We all started life as a baby. We all got to get behind this issue. So.
Absolutely. And I so wish that we could keep talking, because I know I could talk about this for hours, but just thank you so much to my panel for being here and talking about this very important conversation. Thank you so much.
Thank you. Great job.
Please welcome back to the stage Kathleen Koch for a conversation with David Johnson, Deputy Assistant Secretary for Health for the Department of Health and Human Services, Office of Regional Health Operations, and member of the HHS Office on Women's Health Task Force on Maternal Mental Health.
So, David, thank you for joining me.
My pleasure. Appreciate it.
I know you're a member of the task force on maternal mental health, but you just heard a couple of great discussions, and I wondered if you had any thoughts you wanted to share on anything you've heard so far.
Well, certainly a lot of thoughts. First of all, humble to be here, and really thank you for the opportunity and the responsibility, recognizing the responsibility we're here today. I think celebrating this event, it's taken a long time, but it's important. First of all, I think from our previous panelists, the givingness, if that's a word it is today, being able to share and just give the stories and have this reality to this, what's happening out in the real world. That, I think, is the challenge for us who live in DC, that we don't get enough of that, and we need to hear that. I think from our legislators that we're here, I think just one, that they're coming together. They talked about holistic ability, but I think it's important to acknowledge that legislation is part of how we do work. But the givingness of stories, the reality, making sure that we talk about it, reducing these expectations that are being raised, reducing assumptions and making sure that we do share our stories out there, that we're authentic about how we do it, and that we're doing it for the purposefulness of our future. So I think what they shared with us today, again, the weight of that to me to bring back to what we do every day, it's a fantastic responsibility.
So let's talk about the task force. One of the things you put together was first a report to Congress. So let's just briefly touch on what you think was the headline from that. What did you find about maternal mental health in the United States today that was most striking that you put in that report?
Probably two things. One is, one, that it happened,
Okay.
that there's actually action, because that's the one thing that we don't do. We don't do action. Actually, there's probably three things.
Okay.
The unfortunate side is that the data really have not changed.
What do you mean?
They've been poor for a long time, and they continue to be poor. And that this highlights that these data need to improve, right? We talked about we're not going down, right? We need to first level off. But these data have been poor for a very, very long time. And then finally, I think really in thinking about this from a positive standpoint, it's a holistic approach. We talk about all of government. We talk about, and that's not just within the federal government on the executive branch side. We're talking about different branches that are coming together. But the holistic approach, trying to make things more and better. More better data, more better access, more better collaboration among us. We don't spend enough time within the federal government, within our agencies. Not only, HHS is a big agency in of itself. We have a lot of operational divisions that have very specific things to do. But I think what this report highlighted is the importance of not only working within our department, but across. And then also, most importantly, I have the opportunity in my job to really communicate from what happens in DC out into the jurisdictions, is that we're hearing back from the jurisdictions. We need to hear more of that. We need to hear voices. What happens outside the DC and the Beltway is reality. What happens inside DC and the Beltway is something slightly different. The communication doesn't always happen there. So being able to translate and better appreciate the voices. Our colleagues that spoke earlier today, and the colleagues that continue to have spoken that we didn't hear today, but speak every day in the past, and that will continue to speak. That, I think, is the embodiment of the report to me.
All right, let's look at the recommendations. So basically, you came up with a national strategy to improve maternal mental health care, and it included, it's a really long list of recommendations. I highly recommend that you all go and check them out. But would you just give us sort of a summary of what the panel is proposing?
So I think one is when we think about this infrastructure, and I say that infrastructure both from a concrete standpoint, but also from a philosophical perspective. Concretely, we need a structured approach to addressing mental health, which includes reducing silos, reducing the challenges in our fractured healthcare system. Philosophically, it is working together. In health, we often speak about health. We speak about what we see in front of us. Are we living healthy? Are we sleeping? That was one of the, right, I think, no. I wish I was sleeping a little bit more.
Don't we all?
Right, don't we all? I think the other piece of it is talking about human services. And for us in HHS, we think about health and human services as one word. One of the things that I think the report really highlights is ensuring both community involvement from the voice of the individual, hearing lived experience, but also ensuring and talking about how we are supporting individuals outside of health. Social determinants of health are something that we all hear about and we live. The vital conditions is something very similar, and we think about this from a philosophical standpoint. How do we get organizations, not just the federal government, but community associations, to come together? The importance of food, the importance of housing, the importance of all of these other elements that support health. I think the report in of itself embodies that. It talks about this from, again, a philosophical, but also concrete level of ensuring that we are coming together, that this infrastructure is being built. And again, I have to celebrate our legislators today, getting this done so quickly. I mean, speed can happen in DC. It is possible, and it's the will. We just need to continue to push, and I applaud everyone in this field for being able to do that.
Before we go into some of the details that I had some questions about, how is this different from what the White House proposed in 2022 when they released the White House blueprint for addressing the maternal mental health crisis?
So there is a lot of similarities. And I think if we look at the two and look at parallel, the one thing is, I think what the White House blueprint, it set forth a very clear vision. And in doing that, and I think from any organizational standpoint, it gave us the empowerment, or it empowered us, to be able to move forward. And again, from many different sides. I think it supported what has been happening out in the community, what has been happening with associations, NGOs, to be able to continue their work. It empowered us in the federal government to take that extra step. Should we need that all the time? I will tell you, it's a great feeling to have that, to see the leadership from the administration, to see the leadership again from Congress, to be able to support that. So it established this vision for us. I think as we look and really pair the two next to each other, the task force work is operational, if I can use that as more of the example. I think that, again, the vision of the blueprint was high level. It set very nice expectations for us to be able to look, to be able to understand, to be able to have us communicate back out. There's a lack of communication. And I think, again, until we improve that, we're gonna be stuck in the same circle. But the White House blueprint, I think, is the blueprint for us to be able to follow.
So I want to talk about some of the recommendations, the one I brought up to the senators, requiring 6 months of paid family and medical leave, as well as universal child care. I know that is the norm, right? In most other industrialized countries, they have things like that. We're one of the very few that don't. But that's a heavy lift in the U.S. Mm-hmm. I mean, what do you think?
It can be done. It is will. I want to be optimistic about this. Yes, we have challenges for it. But I do think in order to be able to achieve that, we also need an infrastructure of workforce. We need a workforce. Even if we're able to provide that, I don't think there should be an expectation of 6 months or of being alone with your child. I think there needs to be this integration. Parents need to have that ability to be able to socialize as well. The 6 months, in my opinion, should not just be one-on-one with your child and that's the vacuum that you're there. It is to be able to start living. And I think we need, at least within the federal government, at least what I can at least speak to a degree, is ensure that we're establishing pipelines for workforce. That was talked about a little bit more. Ensuring that services actually are clear, that we are promoting what services we have. I talked about human services a little bit earlier, but I do think those are actually the backbone of us to be able to achieve mental health, to achieve physical health, and just to be able to thrive, right? That's what we all want to do. We don't want to just get through the day. Some days we just want to get through the day, but that's a day-to-day thing. We need to thrive. And I think putting forward, and I say very positively, radical approaches of that, right? We're talking about paid leave for months at a time. The rest of the world doesn't. Why can't we? And I think we can, but we do need some supports. We need to make sure that when that does get passed, that we are in the best position to be able to do that and think about thriving and continuing to move forward.
You talked about a pipeline for workforce. So I know that when it comes to mental health care providers, we have a dire shortage here in the United States. I think Kaiser Family Foundation says we have a shortage of more than 8,000 psychiatrists. So talk about the recommendations and how do we, if not get more psychiatrists, then enable other people? Are we talking doulas? Are we talking nurse midwives? Yeah. Who is going to help carry the load?
Yeah, I think everyone, right, it's a village, right? Everyone carries the load. And again, in a positive way. I do think that one supports the other, and I'm not sure which comes first. But I do believe that, and I refer to them usually as the allied workforce, but we talk about community health workers, and they have a slew of names, right? We have perinatal community workers. We have peer support workers, which are the mental health side of community health, and which are actually funded, that we do have financial support for them. It's continuing that and making sure that actually there is there's opportunities for these positions that aren't just acute. I'm going to be this before I get the real job. There is a career here. And I think part of this, and getting back to the question about how do we support 6 months of funding or whatever it is that we need to continue in the postpartum period, it's important to have those supports already there that do support psychiatrists, mental health services. We are pushing a lot on our primary care docs. I'm not being a primary care doc. I'm not sure how much more we can continue to do that. And so there should be this use of better use of telehealth. COVID brought a lot of really challenging things, but it actually brought a lot of positive areas. CARES Act was part of, we have a lot of other legislation was there that expanded telehealth. So I do think as we look to this flexibility and we look to different ways of providing mental health services, not just at the MD level, but realize that there's a continuum of care that everyone needs, and that there's a continuum of staffing, of the workforce that can address us at different parts of our lives. It's not a one-size-fits-all.
So moving forward, what happens next? Because this is basically a roadmap we're talking about, right? Doesn't have funding. So what is the next step? Who pushes this forward?
I will use the I statement, right? We have to, as a federal employee, there's a responsibility that we have. As a task force member, there's a responsibility that we also have. And what's great about our task force here is that it is a true task force. We have feds, we have NGO participants, we have individuals from a swath, and that represent actually the country. So we all have to take our piece of that. How do we do it without the funding? Well, I think it's actually already happening. In my position, I oversee our regional offices. And so we liaise with the states. We liaise with different jurisdictions and organizations. And state associations, private and at the state level, are doing many of these things. There are postpartum visiting programs that are both supported by some jurisdictions, municipal jurisdictions, but also healthcare jurisdictions, for example. So these are occurring right now. And it's great that they have occurred. It's great that we're doing this, but it's taken too much time. Sometimes we just need to act. Take a point, throw the dart at it, and strive for that. And then go to the next approach.
In the interim, while we're waiting for these things to really, the recommendations to get rolling, to have advocates, to get funding, is there anything in particular or any programs that you think the federal government has initiated that are ongoing or just starting right now that are showing a lot of promise? I was curious in particular about the Postpartum Mental Health Collaborative.
Sure. Oh, no, yeah, thank you for referring to that one. So Secretary Javier Becerra, he's the Secretary of the HHS, announced that on Valentine's Day of this past year. And it's a 6-state collaborative. And part of this is data are very important. And it is a pilot. And like I said, I know Iowa's one. There's, I think, 4 other states that start with an N, with M, and then New Mexico. It probably give me 3 seconds. I could probably figure it out. The importance of that is really that this is not just East Coast, not just West Coast. It actually is across the country. And I think this collaborative, the real purpose of it is to allow states to be able to, and I typically talk about states and jurisdictions, to allow them to execute where they are. Legislation happens as a one-size-fits-all. The importance of that is customization, or is lack of customization, right? We want to have something that works. But the importance of getting it out into the states, hearing, this is where it happens. For us in the federal government to support that, to leverage some of the existing programs that we do have. HRSA has a lot of both maternal health, but also health services. How do those support some of these, this collaborative here? So I do think this is an important approach to both execute what they're doing, what works for them, but collect those data so that we are able to be evidence-based or evidence-informed, because it's the promising practices and those best practices that are used to drive some more innovation, and we need to continue to innovate.
David Johnson, Deputy Assistant Secretary for Health and a member of the Task Force on Maternal Mental Health. Thank you so much.
Kathleen,
really
appreciate the
it.
time. I really do. Thank you, everyone.
Please welcome Cheyenne M. Daniels back to the stage and Kamisha Battle Jackson, perinatal, anxiety and depression survivor, and social support and volunteer manager at Postpartum Support Virginia.
Kamisha, thank you so much for joining us. And I just want to give a little bit of a warning to everybody. Kamisha is an absolute delight. She is wonderful, and I could talk to her for hours. So I'm just warning you, you're all going to love her as well.
Thank you.
So, Kamisha,
Yes.
you work with Postpartum Support Virginia to
Yes.
help women dealing with perinatal anxiety and depression.
Yes.
And you came to this work after your experience.
That's correct.
Are you comfortable sharing that experience with our audience today?
I am comfortable. Yes, sure. So I have what you call, I had what you call, what people like to call a pandemic baby. I don't like to use that term. But I was 4 months pregnant. Hadn't even told my principal, I'm a former educator at the time, 4 months pregnant when everything shut down in March. That was the scariest time because I like to be in control. I was not in control in that moment and I'm pregnant with my first child. There was a lot of questions around COVID and testing and my husband being able to be there with me when I give birth or even at my visits, my doctor's visits, he was not present. He stayed in the car. During some visits, I was allowed to FaceTime him in, and it was just not what I expected it to be my first time around. And just to speed up a little bit, I found myself really, really sad about all the thoughts and the hopes and the dreams that I thought that I would be able to have, the baby shower that I didn't have, right? The birthing classes that I didn't get to take, right? And the breathing techniques that I didn't get taught, right? All the things, and I found myself like, why me? Why is this my experience? Well, look, this is why me, right? I'm here to tell you all that I survived it and I did it. And it was difficult, but I'm grateful for my support system that helped me. Shortly after everything shut down, you all know, it was national news, international news, I would say, about what happened, racism that happened in the George Floyd incident. And here I am pregnant with a black boy, with a son. And it crippled me. What am I going to do? How am I going to protect him, right? And so the fear, the everyday fear, just took over my body, and I tried to manage it, and it was scary. It was difficult for me. I would say 36 weeks pregnant. I had some complications, preeclampsia actually. And I was put on medication to help with my blood pressure. But by 37 weeks, I remember I had a doctor's visit. And I go to the doctors, and it's just routine. And, I noticed I had some swelling. I said, oh, that's normal. Okay, some, water retention. Oh, that's normal. Okay. But she says, I think I'm just going to go, you should go over to the hospital and let them run some more tests. But just in case, take your bag. By the way, what'd you eat today? Oatmeal. I'm planning on going to get some food after this, Okay, I'm going to go to the hospital. But she says, go, you don't have to rush, but go grab your bag. So I go home. My husband takes me home. We have our bag packed because I'm type A now. I had my bag packed. I will say that at 37 weeks. And so we go and we go to the hospital, and they say, well, no, we're going to prep you for a C-section. My son was breech at 37 weeks. I also had preeclampsia. And so they told me it would be better if I delivered via cesarean. And so everything started to move so quickly. And I remember in that moment saying to the nurses, wait a minute, can I please just have a minute to pray? Can I call my mom? It's happening right now. And my husband, he's excited. He's throwing on his scrubs, his anything, and I'm looking over and I'm like, this is not what I had planned, right? And so I'm grateful to I had a doula
she wasn't allowed to be there at the time. But I'm grateful to her because she educated me so much, and she poured into me so much. And so my husband and I, we prayed, and I remember I had a phenomenal anesthesiologist, and he came in and he said, this is what we're going to do, and this is how I want you to, sit on the bed or what have you. And the way he communicated to me, and he saw me in that moment, and I remember saying to him, well, is it something you could give me for my anxiety? Because I was so nervous. And so I was able to have a successful cesarean birth. My son is the light of my life. I'm actually sitting here 8 months postpartum with my second son, who is just amazing. And I'm just grateful to be here as a survivor. One of the things that I talked to you, Cheyenne, about is that when I went home, it was different, right? I'm recovering from this major surgery, and I have this baby, and I'm trying to figure out and process all the things that happened in the hospital. And so when I found myself in isolation, right? Because we're all still indoors, locked down, all the things, and I'm terrified because this is pre-vaccine. I'm terrified. I have a newborn baby. I don't want anybody to come in my house. I don't want to take him out. I don't want to, And so my husband went back to work, and I remember the wave. It was like a dark cloud that just came over me. This actually happened in the hospital when he told me that he had jaundice, and I would have to start to give him formula. And I remember that feeling, like I'm not enough. I'm breastfeeding, but I'm not enough. I thought I was doing something right, but it's not helping him, get rid of the jaundice, the bilirubin. And so I remember just feeling like, well, he doesn't need me, so why am I here? I've already, failed. I didn't do this right, I didn't do that right. And so when I went home and my husband went back to work, those things kept coming up for me. They kept coming up for me. The exhaustion, the sleep deprivation really played a role. And so I remember that night, I said to my baby boy, I said, just go to sleep. I nursed him, I bathed him, all the things, because I had a plan. He would not go to sleep. He just kept looking at me, wanting to play and smiling. And so I'm here because my son, because my support system, because my God heard my cry. Because my friends listened to me when I said I wasn't okay. They shared resources with me, which is how I found PSVA. So now,
And we are so lucky that you are here with us and doing this work.
Thank you.
You have two beautiful babies.
Thank you.
Two very beautiful babies who you're the light of their life, I bet you.
Oh, yes.
And one, thank you. Thank you. And you're so strong. You are so strong for being here. And I know you know that now.
Absolutely.
You know that now.
Absolutely.
But tell me about, because one thing I hear is that there were red flags before your pregnancy. And we talked in the previous panel about the importance of screening.
Yes.
Tell me, do you feel that that screening process was emphasized enough in your case? And how, if you had had that screening, do you think it could have helped you?
I did share that I was already seeing a therapist and I had a counselor, right? And I shared with you, there was nothing that I wanted more than to be a mom, right? And so I said, okay, I'm going to do the thing. I'm going to go see a counselor and deal with all my past trauma so I don't pass them down to my children. And I did all those things, right? And so when I was in the pit of that postpartum depression and really perinatal depression, which is during pregnancy, I didn't connect the fact that I had already had struggle with mental illness or, challenges with that. I didn't make the connection that I had anxiety and all those things. And I don't think, and I wish that this did occur, but I don't think that conversation was had at any of my OB office appointments. It was never had, prior to pregnancy. Everything was about baby, but not mama. But mamas matter. Healthy mommy, healthy babies. And so I wish that a physician or a provider would have asked me, hey, how are you doing? How are you feeling even during my pregnancy? And really screened for some of those things, or asked me, hey, do you have a history of this? Are you connected with a therapist? Well, I did my due diligence and I was connected. So that's a great thing. And I was able to connect with my counselor in the pit of my depression. And in fact, I love her immensely. And when I talked to her in that moment, and she asked me, how am I doing? And she asked me, what's going on or what have you. And I remember telling her, no, I don't want to say it. I can't say it. And she said, you have to tell me. You have to tell me. And I did. And I said it. I said I wanted to kill myself to her. And she was phenomenal in getting me the immediate help that I need. So I'm grateful to her in how she connected me with another provider who I was able to get on medication, which I was nervous about because here I am nursing. I'm breastfeeding. What does that look like? How is it going to get into my my milk? Is it going to decrease my supply? None of those things happened. So let me make that clear. 100% exclusively breastfed son, and it helped both of us. I was able to get rest. Right, and so it really benefited me for a provider to ask me, how am I doing?
We've spoken, and again, even with the last panel, about how we often put that onus on mom to say, I need help. Mom has to come forward and say, I need help. When your therapist was able to ask you, when your therapist was able to say, you tell me, let me take that responsibility of asking you how you are, would you have told her if you hadn't been asked?
I'd like to say, Kamisha, myself, I think I would have. I think that I do a great job of advocating for myself, right? I think I do a good job at saying, hey, no, I'm not okay. I think I share with my husband. And I think he's seen me, and we talked about this. He saw me, and he, in retrospect, he said, you were unrecognizable at times. And I want to be clear about some things. It's not always sadness. I was irritable. I was angry. I was frustrated, the slightest little things. Why didn't you wash the nipple of the bottle correct? I mean, it really, and so because, now he's going to be sick and the germs and this. And so the thoughts and everything just started to spiral. And so when I shared with my husband and I shared with people that I wasn't okay, I'm grateful for my village.
That support system we talked about.
That support system. But did they know what to do for me? I don't think so.
So when we think about the support system, when you reflect on your experience, when you reflect on being here and talking with us today, what words of advice do you give, especially to first-time Black mothers who, as you mentioned, you're dealing with systemic racism, you're dealing with bringing a child into a world where we see the news, we see what happens, just yourself and going through those motions of being, as we heard last panel, strong Black woman. What words of advice would you give to first-time Black mothers?
Take off that cape. Take off that cape. Don't let society put these pressures on you. Motherhood is hard. Parenthood It's hard, it's difficult, right? And my advice would be to find your village. Talk to your friends who are also parents, right? And this is not just for mommies, this is dads too, you know? And I put a lot of that emphasis on my husband. I'm like, hey, you can ask some of your friends, do they know somebody that can watch the kids so we can get a date nightly, you know? And so really building that community of support, and that's what we do and have at PSVA. That is how I found PSVA. I found a support group for women of color, and I joined that support group. And I remember that very first call, I had my camera off and AJ sitting on my lap, and I just cried, and I just let it out. And you know, I was seen, I was heard. Right? And so my advice is to, hey, speak up, say something. Say, I just don't, even if it's I don't feel like myself. I can't put my finger on it. I may not call it depression. I may not call it anxiety, but I don't feel like myself. Something's up.
And so on the flip side of that, because again, as we said, it can't always be moms who have to say I'm not okay. It can't always be moms to say I don't feel like myself.
That's correct.
And I want to put this out there because we have heard repeatedly about the importance of a diverse medical workforce. And you did share with me that you had Black workers, medical workers around you.
I did.
So what would you say then to our medical system, to our healthcare providers, on what we need to see from them to help close this gap that Black mothers, Indigenous mothers, mothers in general are facing when it comes to their health?
You know, I think that culturally we become just a society or a people that just likes to check off boxes, right? I've done this, I gave her the clipboard, I asked her the questions, right? But there is a loss of compassion. There's a loss of connection. There's a loss of, it's just, you know, client and provider instead of person to person, mother to mother, father to mother, right? And that's what that anesthesiologist did for me. I don't know if he's a parent, but he saw me, and it felt like he had children and he understood. Right? And he talked to me like a mom. What does a mom need to hear? Right? He talked to me as if, you know, I was a sister, or, you know, someone that he really cared about. Okay, this is how, you know, we're going to do it. And it wasn't like, oh, I'm just going down my list of things when I'm telling you what's going to happen to you. I'm saying this is how I'm going to support you in this. And so the compassion, and I know it's difficult for physicians, but having the time, because sometimes, you know, we have our appointment slots. We see the nurse to come in, and we see, you know, they take the vitals and things, and then we have a short moment with the provider, and then, you know, they're gone, and somebody else does your blood work, and somebody else does. But I wish that I had more time with my provider, and that my providers didn't have the pressure of, okay, I got to go on to my next one, you know, this one, and, you know, I wish I had more time to just sit and for her to ask me, you know, how are you?
Yeah. Kamisha, I want to thank you so much for being here with us today. I told y'all I would keep talking to her if I could because I adore her. But I'm going to ask you one last question that I'm sure is on everybody's minds. How are baby brothers doing?
Oh, they are phenomenal. They love each other. I mean, I'm so looking forward to seeing them together as Amir, which is my youngest, gets a little older because he's only 8 months. But AJ is thrilled to be a big brother. I'm grateful to be back in the workforce with PSVA and to do the work that I do. I'm very passionate about it, as you can see. I'm trying to hold back tears, but I love what I do. I love helping mothers, and I feel really, truthfully, that not only as I'm pouring into the mom, I'm pouring into the child, and that's what I love to do.
Kamisha, thank you so much. Thank you.
Thank you so much.
Thank you, Cheyenne, and thank you, Kamisha. And that brings us to the end of our program. Thanks to all of the wonderful speakers this morning. And on behalf of the Hill and our sponsor, Sage Therapeutics, we'd like to thank everyone who joined us here in the room and online. If you missed any portion of today's discussion, you can find it on thehill.com. Thank you.